What's up, Ninja Nerds? In this video today, we're going to be talking about dilated cardiomyopathy. Before we get started, if you guys like this video, it benefits you, it makes sense, please support us by hitting that like button, commenting down in the comment section, and please subscribe. Also, if you want some amazing notes, some awesome illustrations to follow along and really make sense of this lecture, please go down in the description box below. We'll have a link to our website. Go check that out. Without further ado, let's start talking about dilated cardiomyopathy. All right, so there's different types of cardiomyopathies, right? There's dilated, there's hypertrophic, and there's restrictive cardiomyopathy. We're going to talk about each individual one in an individual video. But what we have to understand is, in general, the general definition of cardiomyopathy is there is some type of disease or there is something that is causing problems with the myocardium of the heart. So there is issues where there is decreased function of the myocardium of the heart. And usually it's not due to an ischemic cause, it's not usually due to a valvular disease, there's something else. Now, believe it or not, the most common cause of someone developing dilated cardiomyopathy is idiopathic. We don't really have a reason why. We don't know why. There may be some suspicion that there's a genetic involvement, but believe it or not, 50% of cases that have dilated cardiomyopathy is usually due to an idiopathic, maybe some type of familial relationship. Now, what could that be? The particular thing that we think is that there may be some type of genetic defect within some of the proteins that are involved within the sarcomere. So the genetic defects that actually exists here may be in a gene called the TTN gene. And this TTN gene controls different proteins that are connecting different parts of the sarcomere proteins. Now, if there is a genetic defect in the sarcomere, what happens is the sarcomere is the structural and functional unit of the actual muscle. So decrease in the sarcomere function will result in a decrease in the actual ventricular contractility. If there's less sarcomere function, this will ultimately result in less contractility of the ventricles and effectively a reduction in cardiac output. That's a problem. So what happens is, in a response to that decrease in cardiac output, our ventricles try to come up with a very interesting way of being able to modify that by dilating their ventricles and trying to make their ventricles a little bit thinner. You'll see why that can be problematic though. So again, one of the particular reasons is idiopathic or some type of familial genetic type of underlying cause, maybe a TTN gene that's in there. The next thing that I want you guys to think about is, could there be an autoimmune relationship? So autoimmune causes. So these could be particularly things such as SLE, so systemic lupus erythematosus, rheumatoid arthritis, and sometimes even polyarteritis nodosa. What may happen in this situation is that you may develop these certain types of autoantibodies and cause particular destruction of the actual myocytes. If you destroy the myocytes, you destroy the actual functional units of the actual cardiac muscle, and this can lead to, effectively, a decrease in the contractility of the muscle. And so again, one of the big things here is that you actually reduce contractility, and contractility may lead to a reduction in cardiac output. Okay? So again, big thing, idiopathic is the most common cause, about 50% of cases. Autoimmune can be one such as SLE, RA, and polyarteritis nodosa. Second one. Now, this is the one that I actually do want you to remember for your exams. Infectious etiologies, particularly viral, is also a very common cause. So if you had to remember the first one, it's idiopathic. Second one, it would be viral. And what I mean by viral is there's a couple different types of viruses, but the two big ones that I really want you to remember here tend to be what's called the Coxsackie B virus. So the Coxsackie B virus, and the other one is HIV. And these viruses may actually cause a myocarditis. It may cause inflammation of the myocardium. If you inflame the myocardium, you decrease the function of the myocardium. If you decrease the function of the myocardium, that can lead to particularly a decrease in the function of the myocardium, such as a decrease in contractility. So these are two different things that I want you to think about. So again, Coxsackie B virus. There's another one called the parvovirus B19. If you really wanted to add an extra one in there, it would be parvovirus, particularly B19. But I really want you to remember the Coxsackie B virus, HIV, and in addition will be the parvovirus B19. Here's another one. This one will definitely likely come up on your exam as well. Usually the clinical vignette in which this can actually be present is a patient is having, they went traveling maybe in South America or Africa and they came back and they were having some low-grade fevers, they were having a rash, they were having periorbital swelling, they were having difficulty swallowing, and they had a mega esophagus. They had difficulty being able to eliminate feces because they had a megacolon, and then they had also chest pain or cardiomyopathy. This is actually due to a nasty bug here, and this nasty bug is called Trypanosoma cruzi. And Trypanosoma cruzi can lead to the disease called Chagas disease. And this is super high yield. Please don't forget this one. So again, Chagas disease would be a patient who you suspect has cardiomyopathy. They went traveling South America, Africa, came back with fevers, rashes, periorbital swelling, megacolon, megaesophagus, and particular signs of dilated cardiomyopathy. Okay, so we got our infectious causes. The next one that I want you guys to think about is stress-induced. Now this one's really interesting. It's really, really interesting. So imagine that you have some type of severe emotional stressor, right? So there's a high emotional stress. Maybe it's the loss of a loved one, right? Maybe it's actually you're pregnant, right? So usually sometimes around the time periods of pregnancy, that can put a lot of, high degrees of stress on the body. So usually, particularly third trimester, up to about 6 months postpartum. These two things, emotional stressors or pregnancy, usually third trimester up to 6 months, can put a lot of stress on your sympathetic nervous system. And when your sympathetic nervous system is on high activation due to these high stress states, well, you know what that does? It increases the release of norepinephrine and then stimulates your adrenal medulla to increase the secretion of epinephrine. Whenever there's lots of norepinephrine and lots of epinephrine, that works on the heart. And it actually really puts a ton of stress on the heart. And what may happen is that you're trying to increase the contractility of the heart. You're trying to increase the heart rate. But over time, that increased stress on the heart for long periods of times, or such an acute, intense stress on the heart, can eventually put too much to the point where the heart starts to go into a failure state. And it starts decreasing in its actual contractility because it's so weak, it's exhausted. You put it through such an emotional crisis. The heart's now crying, right? So these are big things to think about. There's a very specific name for this. Whenever it's stress-induced, that's not related to pregnancy. For pregnancy, there is a specific name. But any kind of like a severe emotional stressors, you know what this is called? For the emotional stressors, this is called Takotsubo cardiomyopathy. And you know what this is called during the pregnancy, particularly third trimester up to about less than 6 months postpartum? This is called peripartum cardiomyopathy. So again, please don't forget these ones. These are special types of cardiomyopathy that are primarily stress-related on the heart. Okay, we got idiopathic, most common one. Second one, autoimmune, that's okay. Infectious, don't forget Coxsackie B, Trypanosoma cruzi. Third one, stress-induced. Emotional stressors, Takotsubo. Pregnancy, peripartum. Either way, both of them put a lot of stress on the heart by causing a lot of catecholaminergic surge. That puts the heart through a very stressful period. It can't keep up with it over a long period of time. What's the next thing? All right, so now what's the next thing that I want you to remember? Toxins or drug-related kind of causes here. So the big ones to remember here is alcohol. So you see you got a wine glass, you're just going tipsy, you're drinking a little bit too much of that alcohol. You're just knocking them back. A little bit too much of that alcohol can put a lot of stress on the heart. Okay, and it's also cardiotoxic. So I want you to think about alcohol as a cardiotoxic agent. If it's cardiotoxic, those toxins can put a lot of destructive damage to these actual cardiac cells. If you destroy the cardiac tissue cells, are you going to have enough of those cardiac tissue cells to maintain enough contractility or myocardial performance? That will lead to a decrease in contractility. Okay, and a decrease in the cardiac performance overall. The next one that I want you to think about is other drugs, maybe that you shouldn't be doing, but again, they're going to have a similar effect to a sympathomimetic, a surge. So you know how whenever you have lots of norepinephrine, epinephrine, it puts a lot of stress on the heart, it causes a lot of vasoconstriction, increases contractility, increases your heart rate. That's a lot of stress for the heart to have to go through. In the same situation, if someone is actually utilizing cocaine, or any type of methamphetamine, that also puts a lot of, increases your sympathetic nervous system activity. And it's also a cardiotoxic drug. The last thing is cardiotoxic drugs that we use to treat cancers. You know there's certain types of cancers, we know when we put someone on a drug is called doxorubicin. So again, what is that drug called? It's called doxorubicin. That is a big one. There's another one called daunorubicin, and there's another one that we actually use to treat breast cancer, and this is called trastuzumab. So imagine that a person is tachycardic, right? They have some type of etiology here. Here's your SA node, here's your AV node, and then here's your Purkinje system. If the SA node is firing excessively, or there's some type of ectopic focus, but regardless, there's lots of electrical activity going on throughout this conduction system. Super, super high heart rates. With these high heart rates, you reduce the diastolic filling. And whenever you reduce the diastolic filling process, you know what that does? That gives there less time for the actual myocardium to get perfused. So that reduces coronary perfusion. And if you reduce coronary perfusion, you reduce oxygen delivery. It puts a lot of stress on the myocardium. And a lot of that stress over long periods of time can cause the myocardium to just kind of tucker out and give up and say, hey, I can't maintain this high degree of stress that you're continually requiring of me. I'm going to have to start slowing down. And so this tachycardia over time, it can lead to a tachycardia-induced cardiomyopathy. So you may see this in conditions such as atrial fibrillation. So if someone is in an atrial fibrillation with a rapid ventricular rate and it's not being treated, that can potentially lead to a tachycardia-induced cardiomyopathy. But one of the big ones is high PVC burdens. So if someone's having tons and tons of PVCs over a long period of time, this can definitely put a lot of stress on that myocardium, and again, over time, reduce its contractility. So that's a big one to think about. Last but not least, don't forget about your metabolic and etiological, metabolic or other particular things to think about. You know when your adrenal medulla has a cancer here and it's just popping, it's just pumping out epinephrine and pumping out norepinephrine. You know what that disease is called? There's a tumor within the adrenal medulla and it's just pumping out tons and tons and tons of this epinephrine, norepinephrine. This condition is called pheochromocytoma. And this high amounts of epinephrine, norepinephrine is just going to increase the stress on the myocardium, right? It's going to increase your heart rate. It's going to increase contractility. It's going to increase afterload. It's going to put a lot of stress. Eventually, the heart will tucker out and reduce the contractility. The other condition that I don't want you guys to forget about is actually called thiamine deficiency. You know thiamine is actually vitamin B1. So in a condition called thiamine deficiency, less thiamine, you know what's really interesting about this condition? Whenever there is less thiamine, what this does is, you know, thiamine is needed to stimulate what's called pyruvate dehydrogenase. And all pyruvate dehydrogenase does is it helps to be able to convert pyruvate into acetyl-CoA. If you can't do that, you can't generate acetyl-CoA. And so what happens is pyruvate starts shunting into making a lot of lactic acid. And so this leads to a lot of lactate. And lactate causes vasodilation. You know what the problem with that is that when it vasodilates those vessels, it leads to what's called AV shunting. And that AV shunting means that if you have blood flowing from an arterial to a venule, it has to go through the capillary beds. If you vasodilate them, it runs through those capillary beds really fast. Doesn't get enough time to be able to dribble off some oxygen. And if that happens, your heart now has to work harder to be able to pump more blood to those tissues because you're just shunting them so quickly, you're not giving enough time for oxygen delivery. And so your heart doesn't know that, and so it just keeps working harder and harder and harder and harder, and eventually it'll tucker out. The last condition that I want you to think about is the same kind of concept. It's actually a condition where your thyroid gland is just pumping out tons and tons of thyroid hormone. And whenever they're pumping out tons of thyroid hormone, this increases your basal metabolic rate. If you increase your basal metabolic rate, your cells have to work harder. This increases your sympathetic nervous system, so now your heart's going to be more stressed. In these situations, this puts too much stress on the heart for long periods of time, and this can also lead to dilated cardiomyopathy. Now, you're probably like, oh my gosh, this is way too much, Zach. I can't remember all of this. This is too much, man. Don't worry. We here at Engineer, we hook you up. So, I want you to remember this particular mnemonic. So if you don't remember all of these things, that's okay. Don't forget this mnemonic to remember the most important causes of someone with dilated cardiomyopathy. And that is a bunch of stuff can cause cardiac dilation. And you'll explain what I mean. Like, we didn't talk about any cardiac dilation. This decreased cardiac contractility and decreased cardiac performance, your heart's got to compensate. And it unfortunately compensates in a way we don't like, and it dilates. And I'll explain why later. But what does that mnemonic, a bunch of stuff can cause cardiac dilation, mean? A for alcohol abuse. B for berry, wet berry. Guess what it's called whenever you have vitamin B1 deficiency that causes dilated cardiomyopathy? Beriberi. So again, B1 deficiency is beriberi, wet beriberi. Can Coxsackie B virus cause chronic cocaine use, cardiac Chagas disease by Trypanosoma cruzi, and dilation, doxorubicin, and daunorubicin toxicity? So you see why now I kind of harped on other particular causes. Please don't forget these. Now that we got this down, let's go over the pathophysiology and complications of dilated cardiomyopathy. All right, let's talk about the pathophysiology and complications of dilated cardiomyopathy. Now, when we have a patient who has this issue, right, that they have that reduced contractility, and the whole thought is that we're putting, what, lots of stress, right? There is lots and lots of stress that's being put onto the heart from all the different things that we talked about, whether that be stress, whether that be an infection, whether that be inflammation. Either way, there's some type of stress being put on the heart to have to work harder. Over time, the heart isn't able to maintain that demand, and the cardiac contractility drops. Now, if there is a reduction in contractility, what's the problem with that? Well, a reduction in contractility could potentially reduce your stroke volume, and a reduction in stroke volume can reduce your cardiac output. And that could drop your blood pressure, right? So here's what we got to think about. What are the things that alter your cardiac output, right? So we know that cardiac output is dependent upon heart rate times stroke volume, right? What are the things that affect stroke volume? And that is what I want you guys to think about. So here we have stroke volume. There's three things that are altering stroke volume, right? One is contractility. Right now, that is the one that we're having some problems with. So we're having issues with the contractility. This is reduced in these patients with dilated cardiomyopathy. What's the other thing that can affect stroke volume? Preload. Preload, right? And because of this, here's the thing. Think about this. And a patient whose contractility decreases, are they able to pump as much blood out of the ventricles? No. And so because of this reduction in contractility, they have a high in systolic volume. So there's more blood that's staying within the ventricles even after the ventricles contract. That's a problem, because now the ventricles are starting to get filled with blood because you can't pump enough of it out. So what if I change my preload? That could potentially be something interesting, right? So preload is the amount of blood that gets into the heart during the diastolic process, right? So whenever a heart's relaxing, if we have more blood coming in, that's more preload. So if I need to increase my preload, I probably need to make my ventricles bigger. Like the actual lumen, the diameter of the ventricles, make it bigger. And so that's what happens. That's the goal here, is that we're trying to increase preload. And this happens via ventricular and even to a degree, atrial dilation. The last thing that alters your stroke volume is your afterload. But this is altered by the renin-angiotensin-aldosterone system. Because whenever you have a low cardiac output, what does that do to your blood pressure? It drops your blood pressure. And when you drop your blood pressure, that may stimulate your renin-angiotensin-aldosterone system. And that's actually going to try to work to increase your afterload, unfortunately. So the one thing that our heart tries to fix is this part right here. Our heart says, hey, I can't really fix the afterload. The problem already with me is the contractility. I can at least fix my preload. So here's what the heart does. It goes through this process where it says, okay, I'm gonna try and do this. I'm gonna try to increase my preload. So in order for me to be able to increase my preload, I'm gonna have to dilate my ventricle. So look at this, look at this crap. Here's the right ventricle. Focus on the left ventricle. Same thing happens though, but now, oh my gosh, the right ventricle and the left ventricle, babushka, dilated like a son of a gun. Now these ventricles are super dilated, and the whole point of them being dilated is to do what? To accommodate more volume. Because the whole thought was if I can accommodate more volume, I'll increase my preload, and if I increase preload, I'll increase stroke volume. But unfortunately, this can work to its disadvantage. So what happens is we go through this process called a remodeling process, and this dilated cardiomyopathy. And what happens is you cause ventricular dilation, right? And the whole point is if you increase the actual ventricles, your thought is that you can increase your preload. And if you increase preload, you'll increase stroke volume, right? That's the thought. But the problem is that you increase preload a little bit too much. You know there's a law, it's called Frank Starling's law of the heart. What does Frank Starling's law of the heart say? As you stretch these sarcomeres, if you get it to the optimal stretching point, the contraction increases. So basically, increase stretch, increase contraction. But it has to be the optimal stretching point. If you stretch the sarcomeres too much beyond their point of optimal contractility, then the contractility goes down. So if you stretch way beyond the optimal length that you want to stretch them, then the contractility will not increase. And that's what starts to happen in this process. They get this big ventricles. Okay? Now, here's the other thing. Because the ventricles dilate, your myocardium has to undergo a remodeling process. So the myocardium has to actually accommodate. And so because it has to accommodate all of this volume, right? So it tries to accommodate all this volume, higher volume. What does the ventricle myocardium do here? Look how thick it is here. Look how dang thin it is there. So now the actual ventricular walls, son of a gun, the ventricular walls will actually start to thin. And this becomes even more problematic because this drops the actual contractility even more. So you see how they were trying to fix this to help the heart out, but this remodeling process actually makes things worse. Now, here's what we actually have to talk about this because this is high yield. This part here, when the myocardium has to accommodate and it actually causes the ventricular walls to get thinner, there's a special name for that. Take a look over here. So imagine here is a myocardial cell. Right? Here's your myocardial cell, and there's two types of situations that this can go through. One is you can put the myocardium, the cells, under a high degree of stress because of high volume. So it's under a high volume state. Or you can put it through a lot of stress where it has to remodel because of a high pressure state. Now, here's the sarcomeres. We just have two of these sarcomeres in a line, right? Watch what happens when we put this actual muscle cell with these sarcomeres under a high degree of volume stress. You see how these sarcomeres are getting added in a series type of pattern? So the sarcomeres are added in series. And that causes them to go through a very special type of hypertrophy called eccentric hypertrophy. And that eccentric hypertrophy is actually what causes these ventricles to become thin and allow for the actual lumen of the left ventricle to dilate to accommodate this high volume. If you put the ventricle myocardial cells under a high degree of pressure, they have to be able to work hard against a high degree of pressure. You see these look what happened. They were in a line. Now I added these kind of parallel to one another. See how they're added parallel to one another? And whenever the sarcomeres are added in parallel, this is another particular term, and we'll see this in a very specific type of condition a little bit later. This is called concentric hypertrophy. And this will actually cause, in this condition, it'll cause the ventricles to get thicker, where the actual myocardial thickness will increase. This happens in diseases such as, we'll just list them now, left ventricular hypertrophy, in situations like high blood pressure, hypertension, aortic stenosis. We'll talk about those later. But that's the big thing. Whereas eccentric hypertrophy is dilated cardiomyopathy. Please don't forget that. Okay, so we have an idea now. There's a reduction in contractility because of those problems. Ventricles try to remodel by increasing preload. They get volume overloaded. Because they get volume overloaded, they dilate the lumen of the ventricles. When they dilate the lumen of the ventricle walls get thin, and because they get thin because of this process of eccentric hypertrophy, their contractility drops. There's a very important law that will make sense of all of this. You ever heard of Laplace's law? Laplace's law says that pressure is equal to 2 times the tension divided by the radius. Think about the problem here with these patients. What's the diameter of their ventricles? Big mamas, right? So their diameter is really increased. Okay? What happens because their ventricular walls get really thin? What happens to their contractility, and therefore the tension, the force that they can generate? What happens there? That drops. So because that drops, think about this. If the numerator drops, what does that do to the pressure? In other words, imagine this ventricle. It had to collapse and push blood out. That's your blood pressure in a way of thinking about that. If the tension drops, that's going to drop the collapsing pressure. If the radius goes up, what does that do to the collapsing pressure? That also drops the collapsing pressure. This can really put a person into a situation where they aren't able to eject enough blood out of their left ventricle. And because of that, causes a very specific types of issue called systolic dysfunction. Don't forget that, okay? All right, so the problem is systolic dysfunction, right? We've made sense of all of this now. So now if the left ventricle is failing, right? Because here's the thing, in dilated cardiomyopathy, it can cause biventricular failure. Often it starts with the left ventricle fails, and that produces the right ventricular failure. And we can make sense of that in a second here, but let's say for a second the left ventricle is failing, right? Because now it isn't able to generate enough blood to eject out, right? So we're not getting enough blood that's being ejected out via the systemic circulation. If that's the case, then the blood actually starts accumulating in the left ventricle and then backing up into the left atria. When it backs up into the left atria, it backs up into the pulmonary circulation, and that backs up into like the pulmonary capillary area and causes fluid to start accumulating in the interstitial spaces. What is that called? Pulmonary edema. And when you get pulmonary edema, what are the common symptoms of that? Obviously, this can lead to shortness of breath. This can lead to dyspnea. This can lead to crackles or rills that can be heard upon auscultation. So things to think about, maybe even a cough. Okay? Now that's one particular thing. So it can cause a low blood pressure. Maybe it can cause some small degree of hypotension, but you're also going to get pulmonary edema. And if you auscultated that, you would be able to hear that, right? So they would have difficulty breathing, they would have potentially hypoxia, they would potentially have rales or crackles on auscultation. Now, if that happens, that puts a lot of actual stress on the pulmonary circulation, right? So when it puts a lot of stress on the pulmonary circulation, now your right ventricle has to work harder. Over time, the right ventricle will start to fail. If the right ventricle starts to fail, it can't pump blood outwards here, right? So this process is being inhibited because the systolic problem is the issue. It's not contracting well. That causes blood to back up into the atria and then down into the inferior vena cava or up into the superior vena cava. If it backs up into the superior vena cava and then up into the brachiocephalics and into the jugular veins, what would that do to the jugular veins? Plump them bad boys up. And that is called jugular venous distension. So that may happen. If it backs up into the inferior vena cava, it can accumulate fluid around the liver, cause the liver to get all kinds of big. And this is called hepatomegaly. And then it could also back up into the lower extremities, cause the lower extremities to get plumped up like the Michelin Man. And then you start getting pedal edema, right? So some type of lower extremity edema. So you can get signs of biventricular failure. If it's right-sided, you get JVD, you get hepatomegaly, you get pedal edema. If it's left-sided failure, you get hypotension and pulmonary edema, right? That should make sense. Now, here's the other thing that's really interesting, right? Whenever you have systolic dysfunction, the left ventricle is, imagine it being very stretchy, okay? Very, very stretchy. So because it's very stretchy, so there's a high degree, let's say high amounts of compliance. Whenever blood is coming in from the atria down into the ventricles, right? So here, let's move these things off to the side a little bit. So imagine for a second that you have blood coming from the atria. So you're going through the diastolic filling process. When blood is coming down into the atria and into the ventricles, it can fill. Whenever you get to that maximum filling process, boom, it causes a really insignificant heart sound, a pathological heart sound, because of this maximum compliance of the left ventricle. Because of that, you hear a very interesting sound, and this is called a S3 heart sound. Don't forget that. That's also very high yield for patients with dilated cardiomyopathy. Okay, so we can get biventricular failure as kind of the overall thing here that I want you guys to establish here, is that they can develop biventricular failure with an additional S3 heart sound. Okay, what are some other things that you need to remember? Well, potential complications as well as some other kind of like interesting things, that specific findings. Okay, here's what I want you to think about. If your ventricles are dilating, right? You know, you have a particular ring that's kind of wrapped around this area where your valves are, right? Imagine there's like a ring here, an annulus type of ring. It's a fibrous tissue ring, and it kind of wraps around the areas and connects with the ventricles. It's kind of like a fibrous skeleton that's a kind of a separation structure between the atria and the ventricle. So imagine there's like this little annulus there. When your ventricles stretch, guess what also stretches? That annulus. So when the ventricles undergo this dilation process and they stretch to open up the actual lumen to increase the cavity of the ventricles, it also stretches the annulus. What hangs off of these annulus? Your valves, right? So that's going to be your tricuspid valve, and that would be your mitral valve. Well, here's what it would look like if we took this and really separated like the actual valvular apparatus, right? Here's your annulus, there's the valve flaps, and then there's the little chordae tendinae connected to the papillary muscles. If your left ventricle was, accumulating blood, but what happens is it contracted, so it underwent this systole process, these valves would easily be able to, coapt together, close, and block blood from coming back into the atria. Right? So there would be no type of regurgitation. But now, you done stretched out that annulus, and now whenever that left ventricle tries to go through the systolic process and pump blood up, unfortunately, what it wants to do is pump blood up this way. But these bad boys are really stretched because this annulus is stretched. So unfortunately, some of the blood will also kind of like regurgitate back into the atria on both of these. All right, so what is this murmur called? Well, because it's affecting the tricuspid valve and the mitral valve, it's a regurgitation murmur. So we call this a mitral regurgitation and tricuspid regurgitation murmur. Now, in that situation, we call these types of murmurs, we give them the term holosystolic murmur. So whenever the person is through the systolic period, whenever their ventricles are actually going through the contractile phase, during that entire process, right, from S1 all the way to the S2, when that ventricle is contracting, you'll be able to hear this actual whooshing sound that's going through the these actual valves, the mitral and tricuspid valve, back into the atria. So you'll get a holosystolic murmur from mitral and tricuspid regurgitation. Okay, the last complication that I need you guys to remember also with dilated cardiomyopathy is that here's another thing. With this actual atria and ventricles, they're both stretching. That's what I told you. I said that there was ventricular dilation, but don't forget, whenever all this remodeling process occurs, because blood is backing up into the atria undergo a remodeling process because they have to accommodate this larger volume now because the left ventricle ain't doing squat to get the blood out. So the atria can undergo a dilation process. When the atria dilate, and sometimes they undergo this electrical remodeling process. The atria don't like being stretched, is the easiest way of saying that. When you stretch those atrial cells, so imagine here's an atrial cell, you done stretched it up. When you stretch these bad boys up, they get ticked off, and it alters their electrical activity. Because you alter the electrical activity, this can lead to arrhythmias. And what type of arrhythmias? Well, atrial arrhythmias, my friends. This can lead to things like atrial fibrillation and maybe supraventricular tachycardias of certain types. So that's big things to remember here is that these patients can develop atrial fibrillation, supraventricular tachycardias, AFib being the more common one. And if someone develops atrial fibrillation, what does that put them at high risk for? It develops a particular increased risk of forming clots. So because of this, there's an increased risk of thrombi, and therefore, if they form a thrombus in their left atrium, or because the ventricle isn't contracting well, blood's kind of sitting within the area, that's another thing, they have an increased risk of embolizing those thrombi that can form in the left ventricle because of decreased systolic function, or thrombi forming in the atria because of atrial fibrillation. All right. These are the complications. This is the pathophysiology, all the clinical features I want you to understand. Let's hit diagnosis now. All right, so let's think about how we diagnose patients with dilated cardiomyopathy. Now, here's the thing. The most definitive test, the test that we would do no matter what, it's going to determine if someone has dilated cardiomyopathy, is an echo. So if you don't want to listen to all this stuff, don't worry about it. You can fast forward and go straight to the echo part. But anytime a patient comes in and they see you, you don't automatically think of, oh, this is dilated cardiomyopathy for sure. No, they present with symptoms that you want to rule out the more significant, fatal, deadly causes. What are those symptoms? Well, they may present with some type of chest pain, they may present with dyspnea, they may present with shortness of breath, right? They may present with palpitations. And so with that being said, oftentimes you want to rule out certain types of cardiopulmonary causes, such as, are they in full-blown acute decompensated heart failure? Are they having an MI? Is there some type of pulmonary process going on? And so what we would do is we would first get a chest x-ray. If they're short of breath, if they have crackles or rales on auscultation, get a chest x-ray. Because maybe what you see is, you see some pulmonary edema because they got fluid all up in the lungs. Because why? That left ventricular systolic failure is causing fluid to back up there. Maybe they even have some pleural effusions too. Sometimes in patients they get pleural effusions as well. So look for pulmonary edema, look for effusions. The other thing is that what I tell you would be a significant finding on these patients with dilated cardiomyopathy. Their ventricles are big, right? So it's going to make the heart look big. So they may have what's called a cardiomegaly. But again, all of these are like non-specific. This does not tell me that the person has dilated cardiomyopathy. This would make me think, oh, they got heart failure. And sometimes that's the common symptoms of patients with dilated cardiomyopathy. Next thing, if patients are having shortness of breath, they're having chest pain, they're having palpitations, anything like that, you should always get a 12-lead EKG. What could a 12-lead EKG show me? Well, if they have dilated cardiomyopathy, again, it's dilating those atria. So sometimes what it may show is it may just show atrial fibrillation. It may show some type of supraventricular tachycardia as well. So that's something to think about. But again, these are not tests that are going to tell me anything about, oh, this is definitely dilated cardiomyopathy. It's just helping me to rule out other particular causes. If I get a chest x-ray, I can rule out pneumonia. I can rule out ARDS. I can rule out a pneumothorax. If I get a 12-lead EKG, I can rule out any type of ischemia, like an ST segment elevation MI, right? So these are particular things that are very important right off the get-go. Now, once I've done these things and I have a degree of suspicion, I go through their medical history and I see things that maybe are ticking off, like, oh, this could be dilated cardiomyopathy. I get an echo. That's the most definitive test. What would the echocardiogram show me? So let's take a look at the echocardiogram. So if we do an echo on a patient, we want to look specifically in a couple different views. There's a couple different views that are very important on the echo. So imagine here I'm taking a look at the heart, right? And here's our right ventricle, here's our left ventricle. What are the big things that you need to think about here? Well, think about our pathophysiology. So first things first, think about the diameter. What happens to the diameter of the ventricles? Next thing is what happens to the wall thickness, right? And last thing is what happens to the ejection fraction. Okay, so the systolic function is the best thing to think about. Well, in these patients, the diameter of their left ventricle and potentially their right ventricle, if they have biventricular failure, is going to be increased. So they're going to have an increased diameter of their left ventricle and right ventricle. Pretty straightforward, right? Wall thickness. Look at these sons of guns. These things are thin as a son of a gun, right? So because of that ventricular dilation, the myocardium had to undergo the eccentric hypertrophy to allow for that volume overload state. And so their wall thickness will be really, really thin. They will have a very decreased wall thickness. Okay, so very, very thin ventricular walls. The other thing is their ejection fraction. This is a big one. So if you remember, the systolic function is decreased. So here, let's think about this as their systolic function, really. Remember I told you that their systolic function was what? It was decreased, right? So we would expect that their ejection fraction would be reduced. Okay? They would have a reduced ejection fraction. We call that HFrEF, heart failure with a reduced ejection fraction. But the other thing here is that they may have certain types of just what's called akinesia. And this may be global. So their entire left ventricle would just not produce a lot of contractility because all of their left ventricle is super thinned out. So you may have what's called global akinesia or hypokinesia. Okay? So it could be akinesia or it may be hypokinesia, but it is global. Pretty much a lot of the ventricle. Okay, those are big things to think about, all right? Now, is there any labs? Is there any tests that I could do that would help me? Really, where the labs would come into play is helping you to maybe rule out the etiology, the cause of someone having a dilated cardiomyopathy. What was the most common cause though? Idiopathic. You're not going to be doing any genetic testing in this patients. It's not really going to yield a lot of information. Could I check for any types of drugs? Yeah. So certain things that I could test for is I could do like a toxicology screen. I could do a tox to rule out that they're not having any type of alcohol abuse or cocaine, methamphetamine usage. I could maybe do a certain type of viral panel. Now, Coxsackie-B virus, not really necessary, but HIV, definitely do some HIV testing. The other thing is, could I test for any autoimmune diseases? I sure as heck can. So I can go ahead and do like an ANA, maybe a rheumatoid factor. So these are certain things that I could do, right? If I wanted to think about particular stress states, Takotsubo, I could ask about any kind of emotional stressors. That's not really a lab though. Were they pregnant? Okay, you can look at them. Oh, yep, you're pregnant. Are they within their third trimester, at least less than 6 months postpartum? These are all things to think about, but we might not need labs to really determine that. Sometimes it's looking through the medical history. If we want to test for certain diseases, think about those causes and think about certain things that I could order to determine those causes. All right, now that we've hit the diagnosis, let's hit it home with the treatment of dilated cardiomyopathy. All right, so let's think about the treatment of someone with dilated cardiomyopathy, right? So go back to pretty much the etiological stuff and how the pathophysiology left to what? Really, the first thing was that there was a reduction in cardiac contractility, right? And that reduction in cardiac contractility led to what? The reduction in contractility led to a reduction in cardiac output, and that led to a reduction in blood pressure. Now, if you guys remember, the reduction in blood pressure, what is that going to do? That's going to stimulate what's called your renin, angiotensin, aldosterone, ADH system. Now, what that will do is this will lead to a very interesting type of remodeling process. So this will lead to cardiac remodeling. And that remodeling process is going to lead to the left ventricular dilation. So the left ventricle will get all kinds of dilated and fat and big. And the ventricle walls will get super thin. All right, so just remember that's kind of the problematic issue here, is they get really dilated and they get really thin ventricular walls and their ejection fraction drops. So now, here's the issue. Because of that, they kind of try to go into this volume overload state to accommodate for this reduction in contractility. Remember what I said? The contractility is down. Renin, angiotensin, aldosterone system will increase the remodeling process, but it also will increase their afterload. Because you know angiotensin 2 does what? It causes vasoconstriction of the arterioles. And if you vasoconstrict the arterioles, that increases the pressure within the arteries, and that puts the stress, a lot of stress on that left ventricle. That's called an increase in afterload. So what the heart tries to do is it tries to increase the preload. But with the increase in preload, it does that. It tries to dilate the ventricles too much. Here's the problem. Remember what I told you? Frank Starling's law of the heart says is that increased stretch means an increase in contractile force. But that is when you're at the optimal length. Guess what happens when you done stretch out that ventricle beyond the optimal length? Guess what you do to your contractile force? You drop it. And so that's the problematic issue. And so whenever these patients go into these super high preload states, it causes their stretch to be too much beyond the optimal length that their contractile force decreases. So what we want to do is think of all the ways that we can try to fix these issues. So what I want to do is I want to not increase the preload because it's going to cause the ventricles to stretch way too much, and that's going to reduce the contractile force. So I want to give drugs that will reduce the preload. I have high afterload. That's putting a lot of stress on that left ventricle. I want to give drugs that can reduce afterload. I have a decrease in contractility. I want to give drugs that are going to increase the contractility of the ventricles. I have a lot of remodeling that's going on of the actual ventricles and the atria, which are causing a lot of issues that could potentially not be fixed in the long-term situation. I want to decrease cardiac remodeling. And then the last thing that can happen here that we got to talk about is because the patients are at high risk for atrial fibrillation and because their systolic function drops, they're at high risk for throwing clots. So we have to talk about anticoagulation. The last thing is because you put them in at deadly risk for really thinning out their atrias and thinning out their ventricles, you put them at risk for VTAC, VFib, deadly arrhythmias. So we got to talk about how we address these. Okay, ready? First case. What can we do to reduce preload? In other words, reduce what? So I want to reduce venous return. Well, I can reduce venous return in two ways. I can reduce venous return by having less fluid, less volume within the blood vessel. What ways would help me to get rid of fluid or less fluid? So I could actually fluid restrict. So that's actually pretty helpful, right? In patients who have heart failure, it's the same thing. You want to fluid restrict them and then restrict certain amounts of sodium. The other thing is, if they have lots of fluids, we can get rid of that fluid. What would that be? Diuretics. So certain types of diuretics may be helpful to reduce preload. You know what else? Avoiding certain types of drugs that drop you. What else is another one that actually reduces your preload? Oh, you know another drug? Nitroglycerin. Nitroglycerin will also drop your preload. So these are things to think about. Why does nitro drop your preload? Because it causes venodilation. If you venodilate, there's less pressure to push blood up into the atria and into the ventricles. That's less venous return. The last thing to think about is actually you can give drugs that, angiotensin 2. Not only does angiotensin 2 cause arterial vasoconstriction, it causes venoconstriction. So if I give drugs that inhibit the renin-angiotensin-aldosterone system, that would also reduce preload. What are those drugs? ACE inhibitors and ARBs. So ACE inhibitors and ARBs. Okay, these are things that I can do. Doesn't this kind of look just like a patient with heart failure? Yeah. So that's the things that we can do to drop the preload. Now, what about reducing afterload? What can we do to reduce afterload? Well, what was the problem for the high afterload? The high afterload was high amounts of renin-angiotensin-aldosterone system activity. Give drugs that inhibit that. So what would that be? ACE inhibitors and ARBs. What else can vasodilate vessels, the arterial side? You know, there's a drug called hydralazine or isosorbide dinitrate is another one. These are also drugs. So hydralazine and another one we're going to abbreviate isosorbide dinitrate. These are drugs that we can give to vasodilate the arteries and reduce the afterload. Okay? What can we do to increase the contractility, my friends? Well, we can give drugs that particularly work to do what? Increase the inotropic action. What is a drug that increases the inotropic action of the heart? You know, there's a drug called digoxin. So digoxin would be another one. So digoxin would actually be a drug because this works to do two things. One is it's a positive inotrope, so it's going to increase the contractility, but it also is a negative chronotrope, meaning it will reduce the heart rate. So it can be good if the patient also has atrial fibrillation. Oh, you're thinking, right? All right. Now, the other thing here is cardiac remodeling. So this whole cardiac remodeling process is dependent upon the renin-angiotensin-aldosterone system. But you know what else it's also dependent upon? It's also, because the renin-angiotensin-aldosterone system is one thing, guess what else gets activated when your blood pressure is low? Another thing is an increase in your sympathetic nervous system. That's another really big one. So if we can give drugs that can alter the renin-angiotensin-aldosterone system and the sympathetic nervous system, that can reduce cardiac remodeling. So what are all the drugs that can reduce the activity of the renin-angiotensin-aldosterone system? So we already hit two of them, ACE inhibitors and ARBs, but there's one more, renin-angiotensin-aldosterone antagonists. So aldosterone antagonists are also drugs that we can consider. You know, spironolactone, eplerenone, these are drugs. What are drugs that we can do to reduce the sympathetic nervous system effect on the heart? Because your sympathetic nervous system is going to be higher, right? What happens if this is higher? It's going to try to do what to your heart rate? Because your blood pressure is low. What will it do to your heart rate to try to increase your blood pressure? Jack that son of a gun up. So it may increase your heart rate. If I can give drugs that particularly work to reduce heart rate affected by the sympathetic nervous system, that'd be good. And that's where drugs like beta blockers can come into play. Metoprolol, esmolol, things of that nature. man, we're good. And also, you can consider calcium channel blockers, but they're not always the best thing to do, okay? So I would try to avoid calcium channel blockers, especially if they have very decompensated heart failure. Probably not the best thing, but beta blockers, yay. Okay? Anticoagulation. Something to think about here. What were the particular causes? Why we would need to anticoagulate someone with dilated cardiomyopathy? Well, the first one we said is that there was a systolic dysfunction. If there's systolic dysfunction, what happens to your actual contractility? There's a reduction in contractility. I'm not able to push as much blood out of the heart. What is that volume of blood that sits in the heart after systole called? There's an increase in your in-systolic volume. There's more blood sitting in the heart. If there's more blood sitting in the heart, it ain't moving. This increases your risk of stasis of blood flow. What does the Virchow's triad say? Increased stasis increases the risk of clots. And so this increases your risk of forming thrombi. And these thrombi, the worrisome situation is that they can quickly break off and form emboli. Okay? So that's one particular reason. The second one is that when you dilate the atria, it causes them to go into this haphazard electrical remodeling process and increases the risk of atrial fibrillation. And this increases the risk of thrombi because they don't have active, very good contractility in the atria. And so blood actually starts to accumulate because they have the same process up here. Stasis of blood flow. Increases the risk of thrombi and increases the risk of emboli. So we should consider anticoagulation, such as things like warfarin if they have a valvular issue, like they have a mechanical heart valve, or things like DOACs, so rivaroxaban, apixaban, dabigatran, things of that nature to prevent them from developing embolic strokes. Yeah? All right. Last but not least, to reduce the risk of arrhythmias. So if someone has atrial fibrillation, that would be a thing that you can consider beta blockers for, right? So that could be a simple fix. They have AFib. A benefit to this may be beta blockers. You can consider calcium channel blockers. But here's the worrisome thing. With the ventricular dilation, we didn't talk about that over there, but with ventricular dilation, that's a bad problem sometimes. And that can also stretch those ventricles out, cause them to become irritated, electrically remodel, and actually lead to VTAC or VFib. This is a deadly arrhythmia. This can cause someone to go into sudden cardiac death. So in certain situations where patients are having arrhythmias or their left ventricular ejection fraction is like less than 25%. We can say less than 35%, I apologize. Less than 35%, and they're having certain types of arrhythmias or they're high risk of ventricular tachycardia, ventricular fibrillation. We don't want to waste any time. We want to reduce the risk of them going into this and actually having a sudden cardiac death. So we can consider something like AICD, an automatic implantable cardiac defibrillator. And so this is basically whenever they go into this VTAC or VFib, it'll shock them to prevent them from going into a sudden cardiac death type of situation. Okay? This covers dilated cardiomyopathy. I hope it made sense. I hope that you all enjoyed it. And as always, until next time.